Good afternoon, and welcome to the launch of the American Economic Liberties Project's Break Up Big Medicine initiative. I'm Nidhi Hegde, the Executive Director of Economic Liberties. For those of you who do not know us, we are a research and advocacy organization focused on the problem of concentrated corporate power in our economy. Since our founding 5 years ago, researching the impact of corporate power in healthcare has been one of our top priorities. And what we have found will likely come as no surprise. Our healthcare system is in critical condition, and core sickness is monopolies. Today, big insurers and other corporate entities employ over three-quarters of our doctors, directing how they provide care. Most metropolitan areas have just one or two healthcare systems controlling the local market, leaving patients with few choices. The three big pharmacy benefit managers, or PBMs, CVS Caremark, Cigna's Express Scripts, and UnitedHealth Group's Optum Rx control nearly 80% of the 6.6 billion prescriptions filled in the US and have been found to mark up life-saving drugs by thousands of dollars. Healthcare spending approaches 20% of our GDP, but the outcomes are really poor. Americans face shorter life expectancies than people in similar countries. Patients are scrambling to fight for their care and face crushing out-of-pocket expenses that can even require them to take on high levels of medical debt. Healthcare workers struggle with worsening working conditions. Independent pharmacists are going out of business. And physicians have less control than ever over how they treat patients. Meanwhile, healthcare conglomerates like UnitedHealth Group report record-breaking profits, so much so that 7 healthcare companies now dominate the Fortune 20. That's up from 0 in 2000. Your big insurance company is now also a big pharmacy benefit manager, a big pharmacist, and a big bank. So today, we draw a line in the sand between those who stand on the side of these ever-growing and greedy healthcare monopolists and the millions of Americans who are at a breaking point when it comes to navigating the US healthcare system. In launching this comprehensive effort to break up the power of big medicine, Economic Liberty stands proudly with the millions of Americans who are just fed up. So today you will hear from pharmacists, physicians, patients, business owners, and advocates on why policymakers at every level of government across the country must move urgently to break up big medicine. Just as the Glass-Steagall Act reigned in big finance after 1929, America is in need of similar structural solutions to address the conflicts of interest that permeate the entire US healthcare system to restore competition, reduce costs, and improve access to quality healthcare. The time is now, and there is no middle ground. So thank you for joining us in this vital effort. We need to build an army to take on these powerful monopolists. So make sure you sign up for breakupbigmedicine.com, where you can get the latest updates on this work. And in fact, we've already gotten some good news today. Just today, we've heard a federal judge in Missouri rejected the 3 major PBMs asked to pause the FTC's in-house case against them over rising insulin costs. So that's a win, and that's momentum. And now to the main program. It's my pleasure today to introduce our first keynote speaker, Representative Jake Auchincloss of Massachusetts' 4th District. Congressman Auchincloss is a leading voice in Congress for healthcare reform, particularly in his efforts to combat predatory drug pricing practices through the Pharmacist Fight Back Act, which targets PBMs that extract approximately $300 billion from the US healthcare system annually. The bill has 60 co-sponsors across party lines, so this is bipartisan. He's a member of the influential Energy and Commerce Committee and brings a deep understanding of the biomedical innovation ecosystem, and his family ties to the healthcare system make him a particularly passionate champion for ensuring that healthcare legislation benefits patients and fosters competition. We're so honored that he's here with us today. Congressman, welcome, and over to you.
Thank you and good afternoon. It's an honor to be here with the Economic Liberties Project, and I am excited to talk about how we can break up the monopolistic practices that have become endemic to how we practice healthcare in this country so that we empower doctors and nurses and pharmacists, and we make patients feel like they are human beings as opposed to means to a reimbursement code. I visit community health centers throughout my district frequently, in Attleboro, where I'm talking to you now, in Fall River. And one of the things that always strikes me about these community health centers is that they feel like how medicine is supposed to be practiced. You walk in and you've got a primary care physician there is a pharmacist, there's a diagnostician, there's an optician, there's an audiologist, they have substance use treatment and mental health treatment. It's like a village. And the practitioners will tell me that while there are certainly challenges with community health centers, they're chronically underfunded, they get to practice medicine the way they envisioned it when they were going through training, because they are not constantly being bullied or price gouged by corporate entities within healthcare that are putting profits ahead of patients. And so we have to think about, how do we veer the US healthcare system towards this model of community health in the same way that countries like Portugal have, where we can get better outcomes and less rent-seeking behavior? Now, this is going to be a journey. The US healthcare system is a $5 trillion enterprise, and it is not going to be moved overnight, but we know that there are pockets that we can address. First and foremost, the pharmacy benefit managers, of course. And I have been a strong backer of the bipartisan PBM reform that banned spread pricing in Medicaid and delinked list prices from compensation in Part D of Medicare. And that was taken out at the last minute because Speaker Johnson got scared by the Pharmaceutical Care Management Association. We're going to fight hard this Congress to get that PBM reform back onto the floor, rather, so that we can get a bipartisan win against this $300 billion industry. We also need to pass My Pharmacist Fight Back Act, which empowers and supports local pharmacists by reimbursing them based on NADAC, based on the actual market-centric cost-plus price for the prescriptions that they are dispersing, so that pharmacists are not having to fight against Fortune 20 corporations who are also their competitors as well as their suppliers, and being torpedoed in their every effort. We also, though, need to start thinking bigger in Congress, beyond taking on these PBMs. We got to think about the fact that over the last 15 years, too much of congressional policy regarding healthcare has been oriented towards subsidizing health insurance companies. The health insurance companies, whether through the Affordable Care Act or through Medicare, have come to Congress and they've said, we're so smart. We have so many actuaries, and we have this brilliant idea about value-based care, and you just give us money. You give us money through premium tax credits in the ACA, you give us money through Medicare Advantage, or you give us money through Medicaid and MCOs, and we'll take care of everything else. We'll make sure that patients do exactly the right thing at the right time, and we'll take cost out of the system, and we'll put the patient first. Well, 15 years on, it's not working out so great. I can see UnitedHealth Group is doing fabulously with their $3 billion in quarterly profit. I can see that Aetna and Cigna and the rest have been making hundreds of billions of dollars off of Medicare Advantage. What I'm not seeing is that patients and providers, whether they're nurses or doctors or pharmacists, feel like they are being empowered, that they can practice medicine in a way that honors the dignity of the human being across the table from them. And so we have to shift away from subsidizing health insurance companies and instead directly providing funding and support and resourcing to our providers themselves through the community health center model, through Section 330, where we are funding people up front and empowering them to practice medicine. And so that, I think, is the overarching goal for us in Congress, is take out the rent seekers, of course, whether they're insurance companies or pharmacy benefit managers, try to implement a Glass-Steagall for healthcare, where, like the bill I introduced with Senator Warren, you can't be an insurance company, or rather a PBM, and own a pharmacy. There's a built-in conflict of interest there. But at a deeper level, stop letting the health insurance companies convince lawmakers that just giving them more money through subsidies is going to deliver value-based care to patients, and instead go to the actual providers, the pharmacists, the nurses, the doctors, the diagnosticians, and see what they need to be able to practice medicine according to their oath, because they want to. Thank you for having me on. Let me give a final shout out here to Antonio Chacha, who we know has been effective because he's getting beat up in the opposition press, which lets you know that he is getting under exactly the right people's skin. So congratulations, Antonio, to being the subject of Oppo research. Lets you know that that you are scaring the right people.
Great. Well, thank you so much. Yes, well, thank you, Rep. Auchincloss. We so appreciate your remarks and being a leader. And as you mentioned, particularly challenging us all to think bigger. The time for small little reforms is over. We need to be pushing the envelope and considering structural solutions. And we so appreciate that you're leading that effort in Congress now. And we're looking forward to your work this term. Thank you. All right. So as our executive director, Nidhi Hegde, mentioned in the opening remarks, this is really the kickoff of a big effort for us at Economic Liberties. First, to introduce myself, I'm Morgan Harper, Director of Policy and Advocacy. But Break Up Big Medicine is all about drawing attention to the core issue that is driving up costs in healthcare and reducing the quality of care. And that is these conflicts of interest and the huge healthcare conglomerates that have become so large and so profitable. And this is not just a wonky DC issue. As we know, healthcare impacts all of us. And unless you're one of the folks leading one of these large healthcare corporations or investing in them and making a ton of money, well, you are part of the millions of people that have an interest in seeing them broken up. And we just have a few people today that are representing the breadth of this coalition that wants to break up big medicine. And I'm excited to kick it off so you can hear directly from the patients, providers, physicians, business owners who are part of this effort and want to share their stories. So we will start with the man who just received well-due recognition from Rep. Auchincloss, Antonio Chacha, to help set the stage a little bit about why these conflicts of interest in big medicine are such a problem right now that needs to be addressed. Antonio?
Thank you. Yep. Thank you, Morgan, and much appreciation to Representative Auchincloss, who's been a tremendously astute thought leader in this space in Congress, where sometimes, good thought isn't necessarily welcome. Look, while a perfect healthcare delivery system eludes every country across the globe, the United States has some significant uniqueness, both good and bad, when compared to our international peers. Specifically, the U.S. suffers from the highest prices of medicines in the world. All across our prescription drug channel, the sticker prices are significantly inflated and disconnected from the underlying actual cost of those medicines and the actual cost of the services rendered by the providers and other intermediaries involved in the distribution of those medicines. Because of what I believe to be well-intentioned policy decisions aimed at getting discounts off those inflated prices, over time, as the focus for drug pricing reality became almost entirely focused on negotiated discounts, we lost our way in the pursuit of actual low prices instead. Over time, the list prices for drugs has arguably exploded, creating greater and greater pressure for government programs, employers, and sick patients to access affordable medicines, not through actual affordable prices, but instead through negotiation off those bloated prices. This philosophical approach has put a great emphasis and reliance on those doing the actual negotiating and how the end payers can maximize their access to those discounts. Simply put, the system has put a near inescapable reliance on large companies who can insulate us from the very inflated drug prices that the system and those same large companies have all had a hand in inflating in the first place. The problem is that our need for medicines is a matter of life or death. And in a world where there are inadequate pressures on drug companies and distributors to lower the price of those medicines, we need unconflicted alignment from the negotiators, especially health insurers and PBMs, to work to maximize value in an otherwise high-priced and high-risk pricing environment. But be clear, every layer of the prescription drug channel, manufacturers, wholesalers, pharmacies, PBMs, GPOs, and a bevy of other players are all comprised of publicly traded companies whose fiduciary obligations are to make more money today than yesterday. As vertical integration across the drug channel grows the conflicts of interest in the supply chain, there is a great need for government payers, employers, and patients to have better transparency, better system alignment, and fair rules of play so that access to medicines is both robust, efficient, and most importantly, in keeping with the public health needs of every American. Thank you.
Great. Thank you, Antonio. And yes, such an important clarification. And this has certainly been our experience at Economic Liberties from our beginning, digging into this industry, the healthcare industry. There's not just one monopoly problem. It's the GPOs, manufacturers are an issue, insurers. And so appreciate you kind of laying the groundwork there, particularly on the prescription drug front. Now we're going to turn to a senior fellow from American Economic Liberties Project, Hayden Rockley, to kind of build on setting that stage of just where exactly these concentration problems lie in the healthcare ecosystem. Hayden?
Thanks so much, Morgan, and thanks to everybody for being with us for this kickoff event. I want to just make one basic point before handing over to our speakers who can talk so much about the experience of big medicine, of corporate medicine today. And it's a point that I so appreciate Congressman Auchincloss making just now. And it's that the system that we have today, the system of corporate medicine, the system that is so rapidly concentrating power in healthcare into the hands of financial investors, large corporate conglomerates, large integrated multi-state hospital systems. It's the product of deliberate policy-making decisions and legal decisions that we've made over the last number of decades. It's a deliberate policy decision each year to outsource our Medicare program. Now, over half of our Medicare program in the form of Medicare Advantage to the nation's largest health insurance companies. Each year, we're cutting checks of hundreds of billions of dollars of public money to the UnitedHealth Cares of the world, the Humanas of the world, to essentially ration care in our system. It's also a product of public policy to support policies and to support judges and lawmakers to allow these big entities to acquire aspects of nearly every aspect of our healthcare delivery system, as we're seeing now, from multi-specialty practices to PBMs, as were mentioned, to ambulatory surgery centers, home health, hospice. That's a product of policy decisions. The same thing can be said, as Antonio was just mentioning, on the prescription drug supply chain. Quite deliberately from the inception, actually, of our Medicare drug benefit that helps our seniors pay for the drugs that they need, we made the policy decision not to just reimburse pharmacies for administering drugs, but again, to outsource the administration of that benefit to our nation's largest insurance companies and their pharmacy benefit managers. And as we've heard from others, and as we probably will hear more, those insurers have also embarked on a strategy of acquiring more and more of the healthcare delivery system and the pharmacy delivery system, most notably pharmacies themselves. So this system of really the logic here, the system of corporate rationing that we decided to build is a deliberate policy decision that we've made. And I, of course, bring up this point because the same decision, the same public policy that has gotten us into this mess presents an opportunity to change public policy. The same public policies can get us out of this mess. And that, of course, can only happen if we can build the organization, if we can build the power, if we can share our stories, if we can come together to collectively exercise our own pressure, exert our own pressure on the political system in demand of policymakers that we organize a system that's actually oriented around clinicians and their patients and their local communities, and not a system that's organized first and foremost for the profits of our country's largest healthcare corporations. So that possibility is why I'm so excited for the launch of the Break Up Big Medicine campaign and to hear from our speakers today who can speak to the day-to-day experience of big medicine, of corporate medicine. So I hand it back to you, Morgan.
Great. Thank you, Hayden, for those remarks. And I will say we're getting some questions in the chat. If our speakers are very efficient, we might even come back and to Hayden and Antonio to address some of those. But know that we are seeing them, and this is an ongoing effort, and we're going to do our best to continue to get to those. But encourage everyone again, breakupbigmedicine.com. That's where a lot of what Hayden and Antonio laid out about the healthcare supply chain and industry we have on that site. So go there, sign up, and continue to stay in the loop. But without further ado, we are moving to some of our practitioners and starting with my sister in the fight, Dr. Emla, who I have to say I'm a little biased because she's also lives in Central Ohio, but we love all of our panels equally. So Dr. Emla, speak to us about what it's like to be a pharmacist right now up against some of these giants.
Well, thank you for having me, Morgan. And I am honored to be here. And when I look at everybody in front of me, I say, nobody wants to jeopardize their health. I am yet to meet somebody who intentionally wants to jeopardize their health. The difference between you and I talking today, or anybody in the audience, at work, 1 minute, we are a patient on the other side of the counter. And when I opened my pharmacy, when I opened Power Pharmacy in 2019, 120 pharmacies had closed in the state of Ohio. And, I thought to myself, I said, this cannot get worse. We're working hard, we're fighting the PBM fight, and we're thinking that this is going to get better. But last year, 2024, 191 pharmacies closed in the state of Ohio. For the first time in over a decade, this is the time that pharmacies in Ohio is less than 2,000. This is creating pharmacy deserts in mostly rural areas. This is creating pharmacy deserts in underserved population areas. The business of pharmacy has become so complex that, I asked myself, why did I become a pharmacist? I became a pharmacist to help people. Nobody wakes up in the morning and comes to the pharmacy and says, I would like to, buy some metformin because it's a wonderful thing to have. Everybody comes to the pharmacy for medication, for inhalers, for life-saving medications. Because from a clinical perspective, it is my responsibility, not only as a pharmacist, but as a mom, as a community leader, to be able to take care of my patients. But the reimbursement below cost, not only for the products that I'm dispensing, which are helping my patients, which are helping my family, the low financial incentives, extremely low financial incentives, which are given to pharmacists to perform the basic healthcare services that I'm supposed to perform. As a pharmacist, I have seen the life-changing effects of medications. It's making it very complex for the business of pharmacy. And as my friend Antonio would say, I love the practice of pharmacy, but I hate the business of pharmacy. We're subject to the winds of PBMs. The PBMs with the fluctuating reimbursements, low reimbursements, restrictive networks, and steering patients towards PBM-owned pharmacies, it is very unhealthy for the life of patients, for the life of our own children. I look at it that everybody coming could be a family member of mine. And I ask myself, am I one of the pharmacies that are going to be closed today? Are you going to walk up to the pharmacy tomorrow to get up your medication and there's a big sign there closed because of these PBMs? What can we do? We need to break up big medicine. We cannot sit in the back room and complain. We need to break up big medicine for the health of ourselves and our families. Thank you very much for having me, Morgan.
Thank you, Dr. Emla Tubo, owner of Powell Pharmacy. And again, just the experience of both a business owner, but a business owner who is trying to be an effective healthcare provider and practitioner. And that's what independent pharmacists are doing so much in their communities throughout the country. And like you were saying, Dr. Emma, just crazy how unsustainable that's become to run a viable business under the pressure of competing with the pharmacies that are owned by these giants. So thank you for sharing your story. Next, we're going to hear from Jenna Riemann-Schneider, who is from the Asthma and Allergy Foundation of America, and kind of building off of Dr. Emla's remarks, a bit more about the patient experience and especially young people, Jenna, I think you're going to touch on. So please, happy to have you.
Yes, thank you, Morgan. So yes, I'm here on behalf of the Asthma and Allergy Foundation of America, also known as AFA. We're the oldest and largest patient organization for the over 100 million people in the United States with asthma or some form of allergic disease. Now, nearly 28 million people in the US have asthma, and 10 people still die every day across the country. So it's not just asthma. It is the most common chronic illness in children and a leading cause of missed school days. Over the past decade, the cost of medications increased significantly and remains a barrier to asthma management. In fact, AFA's 2017 My Life with Asthma report identified cost as the most common reason people with asthma do not use their prescribed treatments. Asthma patients are struggling to access their life-saving medications due to a system where insurers, PBMs, and pharmacies are often owned by the same companies. This vertical integration prioritizes profits over patient health, leading to skyrocketing and often unaffordable out-of-pocket costs for patients, restricted formularies, and limited pharmacy options. Last year, one of the most widely used asthma controller inhalers, Flovent, was discontinued and replaced with a lower cost authorized generic. Good news for patients with asthma, right? Wrong. We immediately started hearing from our community about access issues. Insurers and PBMs were refusing to cover the generic, forcing patients to pay out of pocket, go through lengthy prior authorizations, or switch to a different, often medically inappropriate, especially for children, medication. And the repercussions have been swift and significant. Epic looked at data from over 3 million patients who had been using Flovent prior to the discontinuation, and there was a 17.5% increase in asthma-related hospitalizations in the 3 months after, and a 24% increase in the following 3 to 6 months. So this is impacting patient health every day, and it's not an isolated case. Across the board, PBMs design formularies to favor higher-priced drugs that maximize their profits, while patients bear the burden of inflated out-of-pocket costs, prior authorization barriers, and medication disruptions. And the problem doesn't stop at formularies. PBMs also steer patients towards their owned or affiliated retail, mail order, or specialty pharmacies, taking away patient choice, manipulating the system for their own profit, and as Dr. Emla spoke to, closing the doors of your local pharmacy. We must start putting patients first, ensuring that every patient can afford and access the medications they need as prescribed by their doctor and not dictated by an insurer or a PBM. It is past time that we break up big medicine. Thank you.
Thank you, Jenna. And yeah, I think that's such an important point. And what's happening right now isn't the practice of medicine. And I think we're going to hear from some folks later in the program that will really hit this home. This is the financialization of medicine, the corporatization of medicine, and really getting away from just pure delivery of care. So we need to call it what it is. And so grateful to have you as part of the coalition here, Jenna, and all of your members who around the country are living with some of the harms from this, willing to share their story on their behalf. So thank you. All right, next, and really kind of like re-emphasizing, I think, some of the points that Jenna came up with just and all of our speakers have in terms of the life and death consequences, unfortunately. Bill, I think you are going to be able to speak to that. A self-described angry dad. So I'm not putting that label on you, but I think we're going to hear a little bit more as to why you have adopted that. And also affiliated with patientprotector.us. So Bill Schmitnick, if you want to go ahead and share your story, we would really appreciate it.
Thank you, Morgan. Yeah, good afternoon. My name is Bill Schmitnick. I'm here today, not as a grieving father, but also as an advocate for change. My son, Cole, was 22, and he should still be here, but he, like many others, were caught in a system where profits mattered more than patients, as Jenna just spoke about. Cole needed his medication, but thanks to the top pharmacy benefit managers, or PBMs, access to his affordable prescription has become a nightmare. And these top corporate middlemen control which medications are covered, dictate the reimbursements to local pharmacies. They take massive kickbacks. Excuse me. It's a little tough. I apologize. They take their massive kickbacks from drug manufacturers. Long and short of it, they're driving up the cost for the patients like my son and everybody else. PBMs have shut down independent pharmacies across the nation, leaving communities without access to care. And it's not always just pharmacy care, it's your flu shots and other stuff like that. But when local pharmacies can't survive, the ultimate fact is patients suffer. They lose trusted pharmacists, they lose control of the critical medications, and sometimes, like Cole's case, they lose their lives. This isn't just my story. It's the story of families across the state. and of Wisconsin and the country. They're being crushed by the weight of an unfair system. The Federal Trade Commission has exposed the harm that the PBMs have done, but we're missing the lawmakers' help, as Representative Auchincloss kind of mentioned a little bit. And we've got to make sure we get our legislators engaged. Ultimately, we must reform PBMs, break up the big medicine, demand transparency, fair pricing, put patients over profits. I lost my son to this broken system, but as we start missions like this together, we can make sure no other family has to endure the pain that my wife and I and our family has endured. Long and short of it, today's the day we all start the mission to break up the big medicine.
Thank you, Bill, for sharing your story. I'm so pained by what your family has had to experience, and I think you nailed it that, unfortunately, you're not alone in that. And the type of loss that's happening at the hands and the oversight of these giants and their corporatization of healthcare, we're not going to stand for it anymore. And that's the whole point of Break Up Big Medicine. So thank you again for taking the time to be with us and sharing your experience. Really appreciate it and honored to be in this fight with you as well.
Thank you.
Next, we will turn to the physicians that are joining us and sharing some of their experiences. We've heard a lot about the prescription drug side of things, but I think our next speaker, Dr. Marian Mass, who is from the Free to Care Coalition, is going to be talking a bit more about what it is to be a practicing physician in this system and the challenges around providing that care. So, Dr. Marian Mass, I will turn it to you.
Thank you for having me. Bill, I'm following you. I just want to say I'm so sorry for your and Shannon's loss of Cole. It's absolutely devastating. And Free to Care formed in 2019 and started talking about PBMs, their overt power, their consolidation, their ability to prevent physicians from practicing personal medicine. And now Free to Care is a coalition of patient and physician advocacy organizations. We total 8,070,000 of those are physicians. So even with getting the word out, we still need to expand more. But I think what's really important is telling a patient's story, because when we hear a patient's story, it really sets things into perspective. So actually, this is not a patient of mine. This is a friend who sent me a text. And unbeknownst to me, my friend's teenage high school daughter started having debilitating migraines 5 months ago. 30 missed days of school, 3 inpatient hospitalizations, multiple tried medications. And then the pediatric neurologist took a look at the case, reviewed all the medications that were tried, and suggested another medication, off-label use. It's an expensive medication, but what else are you supposed to do when you've missed 30 days of school and you've had 3 hospitalizations in a 5-month period? That's a lot. It's a lot on a teenager. It's a lot on the teenager's mental health. It's a strain on the family and the other children. As a pediatrician, I take care of families, and I can appreciate that the pediatric neurologist here is doing their best to try to get these migraines under control, but they're not allowed to practice medicine. They're simply told no. So you, the scrub, do all the training. You go and you look the patient in the eye, you look their family in the eye, and then when you're told no, you have to go through the prior authorization part. Physicians spend an average of 12 hours per week on prior authorizations, and through medicines that are run and controlled by the PBMs. You're getting the prior authorizations through those PBMs. So they control that process as well. So you spend all that time and then they still come back and say no. What's the purpose of these insurance companies? Why do we even call them insurance companies? When you are felled with a disease that you did not ask for, you had no idea was coming down the pike, you couldn't plan for, and now you're told it's just not covered and what your doctor wants for you doesn't matter. That's a suit practicing medicine. It's not allowing the scrubs to practice medicine. It's not personal care. It's not what the patients want. And it happens because of all this consolidation that we're talking about. It's past time to break up big medicine.
Thank you, Dr. Marian Mass, for sharing that. I couldn't agree more. I don't even have anything else to add to that. Break up big medicine. It's unbelievable just the amount of power that has been shifted over to these large conglomerates. But I hope a big theme out of today is that we are not powerless by any means. millions and millions of people across this country have stories just like the few that we've heard already. The power is with us, and we have to just come together now and be relentless and not letting anybody off the hook for pushing for structural solutions that will eliminate these conflicts of interest. So thank you for being with us, and we're really honored to have Free to Care and your 8 million members as part of this fight as well. Thank you.
My pleasure.
Okay. So I actually got confused in my own head a little bit. Our next speaker is not a doctor, but we are going to hear from another doctor. But I think there's this tendency also to think of a lot of the issues we're talking about as the healthcare issues. And certainly, if you are somebody that follows the policy world, then everybody gets kind of bucketed in one issue area. But this is healthcare. Healthcare is everyone. And even if you're a business owner in a space that has nothing to do with healthcare, you are going to bump up against some of the issues we're seeing stemming from these conflicts. So next, we are going to hear from Shay Lucero, who is out of New Mexico and runs her own business. Shay, I turn it to you.
Guatsi Haupa, Shay Lucero, Ese, Oikame, Akamesida, Shashkahano, it's in Awashti Sada. Good day, relatives. My name is Shay Lucero. I am a citizen of the pueblos of Acoma and Laguna. I am the matriarch of Earth and Sky Floral Designs in Laguna, New Mexico, USA. Thank you for the opportunity to share how the high cost of healthcare, driven in part by consolidation in the medical industry, has impacted me, my business, and my customers. I have faced challenges when it comes to paying for my own healthcare, which has had a significant impact on my business. In 2023, I was admitted to a hospital due to an ovarian cyst infection. After one general ER trip, I wasn't recovering and needed to go to a women's specialist hospital. Because I live in a rural area, I have to travel 50 or 60 miles just to get there, and my family has to do the same. On top of that, the women's hospital is not in my insurance preferred network. I'm now stuck paying high out-of-pocket expenses many months later. My income is supplemental to my husband's, and as a result of the medical incidents, I have had to increase the price of my items and services I offer just so that I can recoup my health expenses. I found that since I've raised my prices, many of my customers shop elsewhere. I educate my customers that although my costs are higher, the additional services such as rural delivery and quality products are more cost effective than visiting florists in larger towns. Cheaper flowers will cost them time, if nothing else, but I know I may lose business if another shop is cheaper. My experience is not unusual. Research conducted by Small Business Majority found most small business owners say their costs for insurance premiums, deductibles, co-pays, prescription drug co-pays, and hospital visits have risen in the past few years. As a result, they switched to different insurance plans with less coverage, increasing employee and contributions to health plans, and cutting other employee benefits. Some have even had to drop healthcare coverage altogether. I don't currently have full-time employees. My existing employees are seasonal, so they don't receive healthcare benefits. 16 years ago, when I began my business, I did have full-time employees who received health insurance. Today, I wouldn't be able to keep my business open and provide employees with health insurance coverage due to the high costs. Small businesses are strongly supportive of a number of bipartisan solutions being considered by Congress that would tackle rising costs, level the playing field, and increase competition within the hospital and pharmaceutical industries. In particular, small businesses believe healthcare providers should be required to publicly post the prices they charge for services. Additionally, they think the government should ban facility fees and unfair billing practices, set limits on what hospitals can charge for certain services, and have greater authority to block mergers and acquisitions in the healthcare industry. 6 years ago, I also survived the Widowmaker heart attack. The cost of a lifeguard flight from the local ER facility to the heart hospital in Albuquerque was over $40,000 alone. If our insurance company denied the payment, not only would I have had to close my business, but I would be facing medical bankruptcy. There are so many business owners across the U.S. who fear a major medical incident will push them to the brink. The challenge is even greater for business owners of color who historically face inequitable access to capital and emergency resources. It is time to break up big medicine to protect small business owners and the communities they serve. Tawaya, thank you.
Thank you so much, and for sharing your own personal health story in addition to your experience as a business owner. I mean, I think just that comparison of 16 years ago being able to have employees who you could offer benefits to, and now that being just financially not sustainable, I think is a really important lesson for us to all take away from your experience. So thank you again. And also the breadth of the geography here. I mean, we've heard Ohio, Wisconsin, New Mexico. This is bipartisan. This is rural, this is urban, this is Midwestern, this is West Coast, this is East Coast, this is everyone. So if any of this is resonating with you, please join our campaign to break up big medicine. Okay, next I'm breaking my own rules. I'm talking too much. All right, we got to keep moving with our speakers. Dr. Nick Jones from Clear Health Direct Primary Care. The floor is yours.
Hi, thank you for having me. My name is Dr. Nicholas Jones. I'm a family physician out in Oregon in the Pacific Northwest. Like many physicians, I spent over a decade treating uninsured and underinsured patients through medical school and residency. But after residency, when I tried to look for a position, I knew that there were conflicts of interest, both with large hospital systems and with organizations that might be owned by an insurance company. So I specifically sought out physician-owned medical groups where the docs that were in the C-suite, like the chief medical officer, chief executive officer, et cetera, were still seeing patients. And I found an awesome group up in Oregon where I decided to move and start my career. Now, unfortunately, they were in the transition between fee-for-service medicine, which is flat, you get paid per service. So the more patients you see per day, the more money that you make. But they got hit really, really hard during the pandemic when patients didn't want to come in and it wasn't safe to be seeing these patients. And it set them back significantly on their transition to a value-based system because to maximize Medicare reimbursement on these value-based systems, you need multi-million-dollar medical record systems. One that was already mentioned before, Epic. It's really great at analytics and data tracking, and unfortunately, it costs somewhere around $40,000 to $50,000 per year per doctor, which makes it very complicated to stay afloat. So this medical organization was acquired by Optum or UnitedHealth Group. And those physician leaders that I had sought out, and the whole reason why I had moved to Oregon, they had changed from leaders to middle managers where they could get all of the complaints from the staff, but they couldn't really do anything for them. All of these things were now being done the Optum way because of the trends of vertical integration that we've seen. And, if somebody tells you what you need to do to get paid, how much they're going to pay you, when they're going to pay you, it sounds like an employer. But every doctor that is accepting insurance has to follow these rules. And they're going to have, employers that are just a mixture of insurance companies. That's going to be really, really challenging. And especially for physicians that want to spend their career taking care of patients, as it was alluded to earlier, they spend so much of their time doing coding and documentation, and the incentives aren't aligned with delivering better patient care, having better availability, having any insight or transparency into what costs will look like for patients. And it's either, in a fee-for-service model, just as many patients as you can see per day, or in a value-based model, as many diagnostic codes that you can add into the patient's charts to reflect their complexity and risk. So, those were two models that I really couldn't abide by. And so after 3 years, I decided to leave and start an independent physician-owned group. And so there's a movement of direct care physicians that work directly for their patients rather than for insurance companies. We help advocate for our patients and find price transparency. And it just feels a lot more aligned with the mission that most physicians go into. And when there is a physician shortage, we need to advocate for a healthcare system that supports independent medical practices that are owned and operated by physicians rather than publicly traded companies where that fiduciary duty puts profits over patients. So I'm a big advocate for breaking up big medicine. Thank you guys for having me. I appreciate being able to share my story.
Great. Thank you, Dr. Nick. Medicine by spreadsheet is not sustainable. We have a generation of doctors, I think probably multiple generation of doctors at this point that are facing the same decision points that you did, and it might just be opting out altogether of the profession, and that is a major issue for us as a country. So thank you for shedding some light on that. Okay, last but not least from our rally speakers, but we do have one closing keynote. I want to foreshadow that we are going to be hearing from an FTC commissioner to really wrap things up. But next, we turn to Rep. Bowman, also from Oregon, to share some of what's happening at the state level. Rep. Bowman.
Awesome. Thank you so much. It's an honor to be following Dr. Jones as well. Have learned a lot from him and his story in Eugene. So I wanted to elevate a story for what's been happening in Oregon. We've long had a policy in our state called the corporate practice of medicine, which requires physician practices to be owned by advanced practice providers, doctors, nurse practitioners. And that has been the law of the land for over 70 years in this state. And yet, over the last 10 or 15 years, we've seen a rapid escalation of giant corporations and private equity firms buying up these clinics. And so a couple of years ago, when this idea was brought to me to regulate this, I didn't understand how could these two things be true. We have a requirement that physicians own these practices, and yet you have these private equity firms and corporate giants gobbling up clinics. And essentially, there were workarounds in Oregon's state law that need to be closed. We need to stop the weaponization of non-compete agreements and non-disparagement clauses, stock transfer restriction agreements, and other contractual clauses that are used to control physicians, and to your point, are driving physicians out of the field of medicine. But I want to nail down on the situation in Eugene that Dr. Jones experienced. So there was a very successful practice, physician-owned practice, that I think is a perfect case study for this problem. It was sold to Optum, a subsidiary of UnitedHealth Group. Within a few years, you saw over 30 physicians leave the practice, and thousands, over 10,000 local residents who lost their primary care doctor because of it. In the fallout from this situation, there was a community meeting in Eugene, which is a large city in the state of Oregon, and it brought together physician leaders, legislators. It was held by a community group. And I want to read for you what the Optum executive medical director of Oregon said, because I think it perfectly lays out the choices we have in this system. He said, "The experiment of having physician-directed healthcare in this country over the last 70 years didn't work. It didn't work. They believe that physician-directed healthcare is a failed experiment. That is the choice we have. We either are going to have physicians in charge of our medical care, or we are going to allow corporate profit to make decisions about what happens in an exam room." And I'm grateful to be with you to stand up and fight for physician independence. Thank you very much.
Wow. Wow. That's a quote. I wish we had time to come back to our doctors and hear what they think about Optum's perspective, UnitedHealth Group's perspective on who should be running medicine. But like I said, this is an ongoing effort. This is just the launch, and we'll be able to dig into all of this as we continue. So without further ado, well, first, just thank you to all of our speakers and patients, advocates, physicians for sharing their stories. We are going to bring it all together, hearing from Federal Trade Commissioner Alvaro Bedoya to close things out. He is very much at the ground level and getting stories from people about their experiences as small business owners, patients, and we've been very grateful for some of the leadership already shown at the FTC to tackle some of these conflicts of interest in big medicine. So, Commissioner Bedoya, I'll turn it to you.
Thank you. Can you hear me okay?
Yes, perfectly.
Okay, great. I want to start by thanking you and everyone at the American Economic Liberties Project for the work you do in bringing together small business owners, patients, physicians to talk about an issue that cuts clean across party lines, both rural and urban America and everywhere in between. And on that note of cutting across party lines, I would be remiss as someone from the Federal Trade Commission if I did not recognize what happened yesterday, which is that our new chairman, Andrew Ferguson, who's a Republican, publicly announced that he would continue to rely on the merger guidelines issued under Chair Lina Khan together with Assistant Attorney General Jonathan Cantor in 2023. I think this is the clearest sign yet that anti-monopoly isn't for blue America, for red America, it's for everyone. And I think those guidelines are going to make a real difference for small business and labor. And that's a really exciting note this week to touch on. In the time I have with you today, I want to just talk about how important it is that we get a level playing field when it comes to healthcare. And more specifically, that we have a level playing field for rural and urban America when it comes to pharmacy. So you mentioned, I've done some traveling to try to meet with people. All of this starts with meeting and marrying my wife, who's from Louisiana. She is from Kenner, which a lot of folks might know is right next to New Orleans. But her sister, my sister-in-law, settled in Springfield, Louisiana, which is a smaller town off of a small town, which is called Hammond. And so before the pandemic, but especially before we had kids, we would spend a whole lot of time down in Louisiana with my sister-in-law and her family. And one of the things that you learn in rural America is, in a place like that, is that pharmacy isn't just a critical part of the healthcare infrastructure in rural places. It is often the healthcare infrastructure, full stop. It is the one place you can go and talk to a licensed medical professional about your prescriptions, the shots you need to take, the reactions you're having to your medicine. And yes, you can take a long drive, see a physician. Yes, you can take a longer drive and get to a hospital, but it's often that pharmacist who is the first line of medical defense for you. And that's true not just in rural America, but urban America. So that's the first thing, you see. And the second thing you see is that a lot of those areas are much more likely to be served not by a chain pharmacy with a name you recognize, but by a family-owned independent. It turns out a lot of the chain pharmacies don't consider it profitable to serve a lot of the low-income communities that are across urban and rural America. And so for that reason, I think it's really, really important we get that playing field right, just kind of on the paper, so to speak. But there have been a couple of specific things that have happened, stories I've seen, people have encountered that have really underscored the need for this. And I'll just share 3 stories. So my first trip as a commissioner was to Charleston, West Virginia. I met in a little office park on the outskirts of town with a group of physicians, pharmacists, and patients. And the reason I was there was the first story. I had a lot of time in my confirmation process 3 years ago. And one of the things I did is literally go on insurance commissioners' websites to understand what was happening to pharmacy. And I came across the story of a family whose child had cancer. And they went to their pharmacy. It was an independent. And the pharmacist had their prescription behind the pharmacy counter, but he told them that the insurance middleman, the pharmacy benefit manager, had instructed him that he could not dispense the medicine to that family right then and there, that they had to go home and wait for it in the mail for up to a week or 2. And thankfully, because it was on the insurance commissioner's website, it was a story of how the insurance commissioner was able to intervene and get that family their medicine. But that was the first time, I heard an allegation that said to me, you need to look into this. You need to understand what's going on here. So I made that trip out to Charleston, and in that room, what a lot of the pharmacists talked about. This was, I think, 2022, so it's just after the pandemic. They talked about how when the pandemic hit, you all remember there were all sorts of opinions out there about the vaccine. And there were a lot of folks who heard things, on the media they listened to that was critical of the vaccines. But it was this relationship with their local pharmacist who they knew that resulted in a lot of them getting vaccinated. And the vaccination rates in West Virginia were actually a lot higher than a lot of other comparable places as a result of that intervention. And yet what ended up happening was, what ended up appearing in that room was that these independent pharmacies were closing one after another. And one of the things they pointed to is that the most lucrative prescriptions that they had were being sent to pharmacies run by the chain, by the pharmacy middlemen. This is one of the key allegations that they made around something called steering. And one of the things I'll never forget is, you had this room of pharmacists, doctors that prescribe through them, patients that get their medicine through them. And one of the pharmacists said, you know what? I got to tell you something I had to do. I am so close to going bankrupt and turning the lights off that I have taken to selling Jack Daniels to just make rent on the lease that I pay here. And for me, it's more important that I be able to keep the lights on and serve the people that I serve, than the fact that I have to make the decision to sell liquor on premises in order to do that. That jumped out at me. Another set of allegations I heard that has really stuck with me is there's a group of pharmacists from Louisiana that actually came and visited with me when they were up in DC. And they told me a different story about how one of the things that I'd heard about pharmacies in Louisiana is that it's often the independents that are for hurricanes, which are a fact of life down there. It's the independents that are often the last to close before the hurricane comes in and the first to open after it goes through. And so they told me a story about this. This was from 2 years ago. A hurricane came through, really hit hard these two parishes south of New Orleans. And they described how this area that was normally served by, I think they said 20 or 25 pharmacies, was down to 4, I think they said. One was a Walmart pharmacy, and the other 3 were independents. And so they talked about how people started showing up at their pharmacies, because these were a bunch of independent pharmacists, with prescriptions for daily regimen, life-saving medication like insulin. And the screen they were getting served by the PBM was saying, no, you cannot dispense this medicine. They need to go down the street to the chain pharmacy. In this instance, I think they said it was a CVS, but it could be wrong. They need to go get it down at the CVS. And it just so happened that the CVS was under 3 or 4 feet of water. And that is another thing that has really stuck with me. And so, these allegations are so serious. A kid not getting their cancer medicine, someone not getting their insulin medication. This could not be more serious. And so for me personally, right now at the FTC, there's nothing more important than getting to the bottom of what's happening in this industry. So as many of you know, we have a public market study on what is happening with pharmacy middlemen and in that whole, tranche of the economy. I urge you all to read it. But I will just leave you with this thought. In this job, you see every sector of the economy, right? You see food, you see housing, you see labor. Right now, for me, getting this right is the top priority. And I'll leave you on a positive note. Another positive note, I tried to open on a positive note, which is that PBM study that we just issued, the interim study, was voted 5-0. Every member of the commission, Republican and Democrat, voted to move it forward. And I think that just underscores how whatever you think about X or Y or Z in terms of politics, this is just an obvious area where our country is hurting and we need to get it right. So thank you again for having me. Thank you for hosting all these terrific speakers. I've learned a lot in the short time I was on the call, and I hope we do get it right. So thank you all, Morgan. Thank you, AELP. I hope you have a great day.
Thank you so much, Commissioner Bedoya. I mean, you mentioned just some of the work, the investigation that you all have released. It is a long one. Encourage people to go to Break Up Big Medicine for more condensed takeaways from their very comprehensive report, a lawsuit that the FTC has brought against the big 3 PBMs, affiliated GPOs. One of the questions that we're not going to have time to get to is, what about group purchasing organizations, GPOs? That is part of this puzzle. And much more. So really grateful for all the work that you all are doing. And like you said, this should be very much bipartisan. We've already seen that out of the Federal Trade Commission, and look forward to continuing to see more. This is both legislative and on the enforcement side of things to break up big medicine. Thank you. All right, we made it to the end of today, the launch. Again, want to encourage folks to visit the website, breakupbigmedicine.com. This is going to be an ongoing effort. No small reforms will do. I think another big takeaway from this is, once you get this type of concentrated power, vertical integration, it can play out in all sorts of ways. Rep. Bowman mentioned non-compete agreements that a lot of physicians are subject to. That's another area that the Federal Trade Commission has been leading on to try to eradicate those based on a lot of feedback from physicians. The list really goes on, but the momentum is with us. Like our executive director said at the kickoff, there are no rooms for small reforms here. We're drawing a line in the sand, millions of people want to see break up big medicine and want to see big medicine broken up, I should say. And if you're one of them, this is the time to join us. So stay in touch, much more to come. And again, grateful and thanks to all of our speakers for taking time to be with us today and sharing your very powerful stories. And thanks all of you for joining.